Good morning, everyone. Today we'll be discussing one of the most complex intersections in neuropsychiatry, traumatic brain injury, and psychiatric comorbidities. As a physician and a physician associate, your role in recognizing and managing the psychiatric sequelae of TBI is critical. Up to half of all TBI patients develop psychiatric symptoms that can profoundly affect recovery, function, and quality of life. Our goal is to review the neurobiological underpinnings and common psychiatric presentations and evidence-based pharmacological and psychotherapeutic approaches that define comprehensive TBI management. Understanding traumatic brain injury. Let's start by defining what we mean by traumatic brain injury. TBI results from an external mechanical force causing the brain dysfunction classified by the Glasgow-Coma scale. Mild is 13 to 15, moderate is 9 to 12, and severe is 3 to 8. Every level of severity can lead to psychiatric consequences, though the presentation varies widely. In the United States, we see about 2.8 million related TBI hospitalizations and deaths annually. Most result from falls and motor vehicle accidents, while military populations face combat-related injuries. Why does this matter for psychiatry? Because up to 50% of patients with TBI develop psychiatric symptoms, from depression and anxiety to psychosis and aggression. Early recognition determines long-term outcome. What are the neurobiological foundation or the pathophysiology of TBI? TBI is not just mechanical insult. It initiates a cascade of secondary neurobiological changes that shape psychiatric outcomes. Diffuse axonal injury, shearing of white matter tracts, particularly in the corpus callosum and the frontal subcortical circuits, disrupts cognitive and emotional regulation. A neuroinflammatory cascade like chronic microglial activation leads to cytokine release, driving persistent neurodegeneration. Neurotransmitter disruption. Dopamine, serotonin, and acetylcholine pathways are altered, producing motivational deficits, mood instability, and attention problems. Frontal limbic dysregulation. Damage to the orbitofrontal and dorsolateral prefrontal cortex impairs emotional control and executive function, foundation for many post-TBI psychiatric syndromes. What are some of the comorbidities of TBI? Let's review the major psychiatric conditions that frequently arise with TBI. Major depressive disorder. 30 to 50% of cases of TBI have comorbid major depression. It manifests as apathy, anhedonia, and irritability rather than sadness. It's linked to fronto-basal ganglia lesions and functional disability. Anxiety and PTSD, present in up to 30% of patients with TBI. PTSD often coexists with organic anxiety, blurring diagnostic lines. Loss of consciousness complicates trauma memory consolidation. Irritability and aggression. Frontal disinhibition leads to verbal or physical outbursts in 25 to 40% of moderate to severe injuries. Commonly disrupts family and rehabilitation engagement. Secondary psychosis occurs in 3 to 8% of cases, often delayed months or years post-injury, usually linked to frontal and temporal damage. Cognitive behavioral dyscontrol, impulsivity, poor initiation, and executive dysfunction dominate daily impairment. These are not mere personality changes, they are neurobiological and behavioral syndromes with many of those origins. A clinical assessment and diagnostic nuance to this disorder is diagnosing psychiatric illness after TBI can be challenging because cognitive deficits often mimic or mask mood symptoms. Apathy can be mistaken for depression and irritability for mania. You must distinguish primary psychiatric illness from secondary post-TBI syndromes. Key tools include neurological testing to map deficits in attention, memory, and executive function, collateral information from family to detect the behavioral change. It is a stark change when somebody has a TBI, and family members are the best source for that information. These assessments guide treatment selection and prognosis discussions. Uh, so, what about depression and post TBI? Depression is the most common sequela after TBI and affecting nearly half of all patients. It peaks at 6 to 12 months post injury and is 2 to 3 times more likely than in the general population. What is our approach? Pharmacologically, SSRIs are first line. Sertraline, 50 to 200 milligrams, and citalopram, 20 to 40 milligrams, often show strong efficacy and tolerability. Avoid tricyclics. They worsen cognition and carry cardiac risks. Consider methylphenidate for apathy and amotivation. About 10 to 30 milligrams daily is the dose range, especially with frontal involvement. Monitor mood, cognition, suicidal ideation, and functional gain. Start slow and start low. The dosing should be carefully done. Pharmacokinetics are altered in TBI. It is not the same as a regular patient, and so be careful. Anxiety and PTSD. TBI coexists with PTSD and generalized anxiety. The challenge lies in separating organic hyperarousal from trauma re-experiencing. First line medications, SSRIs and SNRIs actually. Prazosin between 2 and 16 milligrams at night for nightmares and sleep disturbances. For SSRIs and SNRIs, sertraline and venlafaxine are very good. Avoid benzodiazepines. They impair cognition, increase fall risk, and can paradoxically disinhibit behavior and have a different effect than we would normally expect from these medications. Integrate trauma-focused psychotherapy. Once cognition stabilizes, cognitive rehabilitation may be needed before trauma work begins. Irritability and aggression. These symptoms are amongst the most distressing for caregivers. They result from orbitofrontal and ventromedial prefrontal injuries, leading to loss of impulse control. Some of the strategies are beta blockers, propranolol 20 milligrams to 120 milligrams daily, just to reduce aggression through central noradrenergic modulation. Anticonvulsants like Depakote or valproic acid or carbamazepine stabilize mood and reduce impulsivity. SSRIs help modulate emotional reactivity. Amantadine, 100 to 400 milligrams, can reduce irritability while improving alertness. Always monitor for hypotension, sedation, and liver function changes. Psychosis after TBI. Post-traumatic psychosis is uncommon, about 3 to 8% of patients, but clinically can be significant. It typically presents late with frontal or temporal lobe lesions, and the treatment is such: low dose atypical antipsychotics, risperidone 0.5 to 3 milligrams, or quetiapine 25 to 300 milligrams. Avoid high potency typicals like Haldol, which exacerbate cognitive deficits. Rule out post-ictal psychosis. delirium, or substance effects. Remember, seizure comorbidity is present in up to 20% of moderate to severe TBI cases. Make sure to understand that cognitive impairment is by far the most detrimental in a patient who already has a TBI. Memory can be already impaired organically, and this can just worsen with any of the cognitive issues that typical antipsychotics do give. Cognitive impairment and apathy. You can solve this, and cognitive slowing and apathy often define chronic TBI, and our pharmacological goals are to enhance attention, arousal, and motivation. Options include methylphenidate for attention and processing speed, modafinil or amantadine for wakefulness and executive activation, donepezil, DONEPEZIL, 5 to 10 milligrams may improve memory through results, but they're mixed. Monitor for agitation or anxiety. Stimulants can worsen frontal lobe irritability if dosed too aggressively. So, sleep and fatigue management. Sleep dysregulation affects about 65% of TBI patients. Circadian disruption, fatigue, and hypersomnia all reduce rehabilitation potential. Non-pharmacological first. Sleep hygiene, structured wake cycles, and light therapy. Then consider melatonin, 3 to 10 milligrams for circadian rhythm normalization, trazodone, 25 to 100 milligrams for sleep initiation, modafinil or R-modafinil for daytime fatigue. Avoid sedating antipsychotics, they impair cognition. The multimodal management approach of knowing that no single treatment is sufficient, optimal outcomes arise from multimodal and interdisciplinary care. Cognitive rehabilitation for attention and memory training, psychotherapy modified for cognitive deficits, shorter or more concrete sessions, family education to set expectations and teach environmental adaptations, interdisciplinary collaboration among psychiatry, neurology, physiatry, and neuropsychology ensures continuity and safety. Always screen for comorbid substance use and chronic pain, which can derail recovery. Long-term considerations. Medication and monitoring. Medication metabolism is altered after TBI, so dosing must be conservative. Start at half the normal dose. Titrate slowly and monitor closely. Reassess cognition every 3 to 6 months. Track mood scales. Evaluate function at home and work. Coordinate seizure management with neurology and ensure holistic follow-up. So here's a clinical case. Let's apply this to this real scenario. A 35-year-old male with 6 months post-MVA presents with irritability, depression, and executive dysfunction. Treatment was started with sertraline at 25 milligrams, increased to 100 milligrams for mood and irritability. Added propranolol 20 milligrams twice a day, increased to 40 milligrams twice a day for impulse control. Combined with CBT and cognitive rehabilitation, educated the spouse on behavioral changes. After 3 months, the PHQ-9 dropped from 18 to 8. Verbal outbursts diminished, and with the patient successfully returned to part-time work. This illustrates how integrated treatment and family collaboration optimize recovery. Key takeaways. TBI is both a neurological and psychiatric illness. Treat symptom domains, depression, anxiety, irritability individually. This is the only place where symptom management can be actually beneficial. Avoid medications with high cognitive burden or seizure risk. Integrate pharmacological and rehabilitative and psychotherapeutic strategies. Always coordinate care and definitely educate families. And above all, remember, these patients just don't need symptom control, they need recovery of self. Well, till next time, thank you so much.